So the next speaker is Dr. Ryder Gwinn, who is a neurosurgeon at Swedish Neuroscience Institute, and he's going to tell you about a very interesting technique for treatment of certain symptoms of Parkinson's.
Great, thank you. I'd like to thank the APDA for inviting me to speak today, and I am just really impressed at how many people have showed up today and are interested in research for Parkinson's. I was excited to see it, but then I also realized that what it means is that we're not doing a very good job right now in treating Parkinson's disease, and otherwise there wouldn't be so many people here and interested. And I just appreciate that everybody's coming to kind of hold our feet to the fire and make sure that we get better solutions. So I'd like to talk today about one potential solution for some of the symptoms associated with Parkinson's disease. This is basically a tool that we now have available, relatively new, to interact with the nervous system. And it's a tool called MRI-guided focused ultrasound. And basically, what this is a technique to be able to heat up very tiny parts of the brain, maybe about the size of an M&M, up to temperatures where the cells in that region no longer function. And we know that if we can interact with the nervous system that way, we can shut down parts of the brain that are causing bad effects in patients with Parkinson's. So how does this tool work? Basically, there are two major components to the technology. One is that there is what's called a phased array, where basically they're ultrasound transducers that can create ultrasound waves that then travel through water, through the skull, deep into the brain. And where they all cross together, the temperature rises more than where each path is by itself. So it really focuses the ultrasound much like a lens focuses sunlight. And so you can get very significant temperature changes in a very, very focal area. The other major advancement is the ability to do this in the MRI scanner and do an MRI continuously while we're looking at this. And what we can see then is that we can see how much the temperature goes up and exactly where it goes up in the brain. And that way we can track where our target is and heat it up only where it needs to be. Then this technology has been put together in one machine that is made by a company from Israel called Insightec, and basically it has over 1,000 elements of these transducers that are all put into a helmet and a water bath, and this is placed over the head in a patient where we can then interact with them in the MRI suite while we're conducting this therapy. And so, again, what we're trying to do is raise the temperature to certain levels in the brain. And we know that if we raise the temperature above about 42 degrees Celsius, things start happening. Initially, the cells stop working, although they don't get permanently injured. And so what we can do is interact with patients while we're heating up a certain area of the brain to first make sure it's in the right place, and then to actually verify that the physiology of the target is behaving the way we want it to. So if somebody's having side effects, we can basically move the target to a different place where we no longer will see the side effects. We can also do this in what we call sonications or iterations, where we're gradually increasing the heat and looking for a beneficial effect as well while they're right there in the operating room. And this is, or in the MRI scanner, this is analogous to what we do with deep brain stimulation for movement disorders as well. So this technology was first used in the United States here to treat patients with essential tremor. And we were involved, along with 8 other centers, in a trial that finished a couple of years ago, basically to look to see if we could heat up a part of the brain called the VIM nucleus of the thalamus for treating essential tremor. This is a target that we use for deep brain stimulation and has also been used with gamma knife therapies. And so we basically showed that with this technology, we can reduce patients' tremors by about 70%, and that this is a fairly durable result that can last more than, we have a 3-year outcome publication that should be coming out soon showing that it's a fairly durable result. And again, there's about a 70% reduction in tremor in these patients, which is very analogous to what we get with deep brain stimulation. We actually have now conducted another study in patients with Parkinson's disease, looking at the same target that we used for essential tremor, so the same VIM target. And this is thought to, again, help with tremor in patients with Parkinson's disease. This target does not work for the other symptoms of Parkinson's disease, but we had about 27 patients that were randomized to either getting the real treatment or a sham treatment and followed them for a year afterwards. And we can see from this graph here that the sham patients actually did get a little bit better for a while, but then got a little bit worse again, whereas the treatment patients had a marked improvement, about 62% improvement in their scores for tremor up to about one year after the treatment. So we know that we can interact with the brain in a meaningful and durable way for patients with Parkinson's disease, but really only treating the symptoms of tremor up till now. And this is now a FDA-approved treatment for patients with what we call tremor-predominant Parkinson's disease. We don't have reimbursement set up by Medicare yet. It just was approved in December of 2018, but we're excited to be able to offer it soon. But what I'm really here to talk about is the study that we're participating in right now, which is using this focused ultrasound technology for a different target. This is a part of the brain called the globus pallidus internus. We've actually interacted with this part of the brain with DBS for many, many years now, and we know that can be very effective to try to shut down this nucleus within the brain to treat not just tremor, but also motor fluctuations in patients with Parkinson's disease. And so that's what we're after right now. We have a trial underway that will treat 116 patients at up to 18 centers. And again, it's a sham-controlled trial, so some patients will get the real treatment, some patients will get a sham treatment, 3 to 1, using this technology, and then we'll follow them for a year afterwards with visits at 1 week, 1 month, 3 months, 6 months, and then 12 months, and then follow them annually for 5 years afterwards. And what we're really looking for is improvement in the motor fluctuations and dyskinesias that patients have with Parkinson's disease. So we want patients who are not terribly, terribly advanced and are still responding well to medications, but maybe having significant fluctuations in their abilities to move and may have dyskinesias, which are these kind of irrepressible movements that come when patients are over-medicated as well. And so patients who are fluctuating back and forth between freezing and having dyskinesias are some good candidates for this trial. We're basically looking at something called the Unified Dyskinesia Rating Scale as our primary outcome, and then looking at secondary endpoints, including other measurements on the UPDRS scale, motor scores, and then looking at activities of daily living, motor complications, and then side effects that might be presenting with this kind of treatment. The target that we're after is very close to structures in the brain that control vision, as well as motor function on the opposite side of the body, so we have to be very careful not to disrupt these other circuitry that are very nearby. And so right now we are recruiting for this. If people are interested, please stop by. I'm at the nondescript table in the back, and we have a sign-up sheet if anybody would like to participate. Thank you.
So thank you very much, and if there's anybody with questions, but I'll lead off and ask, if you are in the sham arm, at what point do you get to active treatment?
Yeah. Good question. So the blinded phase lasts for 3 months, and so if you participate in the trial, we don't tell you initially whether we're giving you the real treatment or the sham treatment. We hope that most people will be able to figure it out fairly quickly if they're getting much better with the real treatment. But people that do get the sham treatment then can have the real treatment done 3 months later. So 3 months is the most you would have to go without getting the real treatment.
Any other questions? If not, I can ask Dr. Gwinn. you mentioned that this is also the same target that people get for deep brain stimulation. So, if you're thinking about clinical trial versus deep brain stimulation, how would a patient decide what to do?
Right. So, yeah, that's a very good question. There are very good treatments for Parkinson's disease, the motor symptoms with deep brain stimulation today. Deep brain stimulation is something we do every week, and I really love as a treatment for Parkinson's, but it's not for everybody. We have to make a hole in the skull. We have to place a wire into the brain. We have to then tunnel it to a battery that we place below the skin. It requires multiple programming sessions to be able to get this optimized for a patient. For patients that have significant medical problems or have to be on chronic blood thinners, this can be an issue to undergo this kind of therapy. So this is a one-time therapy with no implants. In fact, we don't make any incision at all. It's completely incisionless. And so we think many people will prefer to have that kind of therapy as opposed to deep brain stimulation.
Thank you very much. And